Good day to everybody. I would like to thank Professor Lies for this kind invitation, and also to Imperial College and Samsung for having organized this webinar. So I will talk about the abnormalities of the corpus callosum and the cavum septum pellucidi. Based on the ISO guidelines, we know that the cavum septum pellucidi visualization is absolutely a required structure to be seen at mid-trimester fetal anomaly scan. So at the screening examination, it should be seen in a transverse view of the fetal head at the so-called transventricular and transthalamic view. The transthalamic view also is the view of the plane where we would measure the biparietal diameter and the head circumference, and that plane is parallel but a little bit more caudal to the transventricular plane. The visualization of the cavum septum pellucidi is very important, as the midline anomalies are mainly depicted based on the analysis of the cavum septum pellucidi. So the non-visualization or an abnormal appearance of cavum septum pellucidi is associated with a number of cerebral malformations. So the first step is to be able to identify what is the normal cavum septum pellucidi appearance, and not also, but also the appearance of the anterior complex might be very useful. So in this slide, we can see the normal appearance of the cavum septum pellucidi, and this is a transitory fluid-filled cavity which is located between the two thin membranes that appears around 18 weeks of gestations. And the appearance of the cavum septum pellucidi and the ultrasound is as a small box, which we can see in red color. It usually disappears in late gestation or in the early neonatal period, as the membranes usually fuse to form the septum pellucidum. So, a failure to demonstrate cavum septum pellucidi before 18 or after 37 weeks might be a normal finding. The frontal or anterior horns, which we can see in yellow color, appear as two comma-shaped fluid-filled structures that are located on both sides of cavum septum pellucidi. They have a well-defined lateral wall and are separated medially by the cavum septum pellucidi. The visualization of both frontal horns is important, while a free communication between them indicates an absence of cavum septum pellucidi, which it might be a pathological finding. Anteriorly to the cavum septum pellucidi, and you can see here displayed in a blue color, we have a genu of the corpus callosum, which can be nicely identified. Next, we have a pericallosal sulcus and the anterior part of the interhemispheric fissure that can be seen. This together resembles an image of an anchor. So it's very important to see this image when we are analyzing the anterior complex. So the visualization of the anterior complex is important, while for example, in the complete agenesis of the corpus callosum, the absence of the corpus callosum will determine an upward displacement of the third vertical, and also, for example, an incomplete cleavage of the interhemispheric fissure. It's a common finding in milder forms of holoprosencephaly, such as the lobar holoprosencephaly. We have to be aware also of the pitfalls, so we have to be very certain of the plane in which we are assessing the concept pellucidi. So for example, if you look at this image below, you can see here that there is something that might recall the concept pellucidi, but to be very precise, we can see 3 lines, and in these cases a multiplanar view can be very helpful, because we can see in this case that we are much more caudal in the assessment, and what we are assessing is the fornices and not the concept pellucidi, and sometimes this can be a source of a mistaken identification of concept pellucidi where there is no concept pellucidi. So this is a very important consideration. When there is a doubt about the concept pellucidi anatomy, the very useful plane is the coronal plane. The coronal plane evaluation is not part of screening, but it's part of an advanced systemic nervous center evaluation. However, many practitioners will perform this evaluation also as part of the screening, especially if there is some doubt about the concept pellucidi appearance in the transverse view. So the most important plane in coronal view for the concept pellucidi evaluation is the so-called transcaudate plane. And what we can see in this plane is the frontal horns. We can see the concept pellucidi, of course, in red color. Then we can see the frontal horns of the lateral ventricles, which are present in yellow, and again they have to be separated from the concept pellucidi. And the concept pellucidi has these triangular trapezoid structures, and it is situated below the corpus callosum. And the corpus callosum here, it's represented in the blue color, and what we can see is the anterior part of the body of the corpus callosum. And finally, what we can see, and this is very important to visualize this, the coronal plane shows very nicely the cerebral falx, meaning that the two hemispheres are anteriorly separated. In the coronal view, also we can see the caudate nuclei. You can see represented here with the green arrows that are located within the basal nuclei complex, which is represented by the yellow arrow heads. Also, we can see the ganglionic eminence, which is represented here in red arrows. And the ganglionic eminence, it has been shown that might be an important structure to evaluate in case of malformations of cortical development, as you can see in this paper by Professor Guy and his group. So the ganglionic eminence is a transient proliferative area which is located inferolaterally to the frontal horns of the lateral ventricles, and it has these gamma aminobutyric acid interneurons, which are neurons that contribute to the development of the basal ganglia and cerebral cortex. So the cavitation or enlargement, as you can see here, of ganglionic eminence might be an early sign of malformations of cortical development, and this will be present in around 36% of cases. Another important plane that is part of advanced systemic nervous system evaluation is the mid-sagittal or median plane, which also is the reference plane for assessing all major midline organs and their anomalies. The following structures can be identified. For sure, we can see, and this is the best plane to assess directly, the corpus callosum. And the corpus callosum, we know, is the largest commissure that connects the two hemispheres. And particularly, what we can evaluate is the four parts of the corpus callosum. So, from anterior to posterior part, we can see the rostrum, the genu, the body, and the last, the splenium part of the corpus callosum. This plane also will show very nicely the relationship between the corpus callosum and the cavum septum pellucidi in red color, and posteriorly, when present, and especially later in gestation, we can observe the cavum verge. Also, we can see the fornix, which is located above the thalami, and we can see also the third ventricle. In this view, we can assess also the infratentorial structures, that is the fourth ventricle, the cerebral vermis, sylvian aqueduct, but this one, it's better if we assess throughout the posterior fontanelle. Of course, we can measure the cavum septum pellucidi, and there are different reference ranges that have been proposed. Here you can see a reference based on gestational age and also based on the relations to biparietal diameter. Also, there have been reference ranges proposed on MRI. But I would really want to underline a very important point, which is that the quality of the studies and the methodology between the studies that published on the reference ranges is quite different. And in this systematic review from 2023, what we can see, for example, is that if we assess the measurement of the corpus callosum reference ranges on two-dimensional ultrasound, we can see that the 10th percentile can change really significantly, going from one study around 13 millimeters and on the other study around 70 millimeters. And this is a huge difference if we think on something that is long around 19 or 20 millimeters. Also, we have to be aware that there might be some differences in the measurements and reference ranges if we measure a structure by 2 or 3D ultrasound. And for this reason, and I must say that I really agree with this good practice point, is that the ISO guidelines recommended not to base our evaluation strictly on quantitative evaluation, but the recommendation is to assess more on a qualitative basis, while there are some aspects of callosal biometry, of corpus callosum biometry, that might be difficult to interpret, and that also not necessarily is associated with an abnormality. So really, we should, with our eyes, assess if the corpus callosum is it's normal, or if it's our impression that there is a part of it missing. So, what might be an abnormal appearance of cavum septum pellucidi on routine scan? So, we have to recall ourselves that we have to see the concept of pellucidity between 18 and 37 weeks, and we can find ourselves in front of an abnormal appearance. As you can see some images, we can have abnormal dimensions, so it can be too small, it can be too big, or we can have a situation when we are really not able to find the concept of pellucidum. So in this case, what will be what is the possibility of the differential diagnosis, and I will present my flowchart that I use for many years. So if you see the video, there is a situation that we really are not sure if we can see or not the concept of pellucidity. In these cases, I think one of the first questions we should ask ourselves is, are the lateral ventricles separated? And this, in this coronal view, you can see that indeed the lateral ventricles are separated. Then the next question we should ask ourselves is the corpus callosum present? And on the sagittal view, I can see that there is a corpus callosum. So if we are in this situation, then we have a situation of the so-called obliterated concept of pellucidity. So what is this situation? It's a situation where we have the concept of pellucidity, but inside the concept of pellucidity we will not have an anechoic appearance, but rather we will have some echogenic appearance and echoes. There is not a lot of literature about this situation. The first paper was published by Professor Malinger in 2012, and there were 16 cases, and the paper stated that we have a good prognosis if this is the only finding, and in apparently isolated obliterated concept of pellucidity, there was a motor or language delay in one case of 16, which makes around 6%. But now I will present you a case that we had a few years ago. You can see the images in B mode, which really resembles the appearance of the obliterated concept of pellucidity. Then we performed an MRI, which you can see here. And is there anything abnormal that we can observe? Yes, if you look carefully, here we are at 20 weeks, but if you look carefully at the frontoparietal area of the hemispheres, you can see that on one side we have some irregular and some hyperdensive appearance of the brain. So this case had a very poor prognosis because this neonate had a polymicrogyria and developed an epilepsy that was not responding to triple pharmacological therapy, and you can see MRI in a postnatal period with some really important brain bleeding, and this baby died at after 3 days of birth. And on exome analysis, we found genetic mutation of the PTEN gene. So this stimulated us to look at the literature, and we found some other case reports of apparently isolated obliterated concept of pellucidity that had an adverse outcome, and we performed this retrospective study with some other groups, and we managed to identify 45 cases of obliterated conceptive pellucidity that had at the second trimester a neurosonography. And in the cases that MRI was performed, you can see that the added value of the MRI was around 5%. After the third trimester evaluation, in 1/3 of cases persisted obliterated conceptive pellucidity, while in 2/3 of the cases there was some fluid visible inside the conceptive pellucidity. But what is the most important consideration is that in around 10% of apparently isolated obliterated cavum septum pellucidity, in 10% we had some abnormal outcome. In 2 cases a speech delay, in 1 case a Noonan syndrome, and 1 case with severe neurological impairment. Now I know you might criticize this study. This is a retrospective study with, of course, lot of biases, but I would use this study as the let's say a proposal for research groups to publish more prospective series on obliterated conceptive pellucidity so that we can give a good counseling to our patients. Then we can have a situation like the one you see in a video clip. So here really I cannot see again the concept of pellucidity. I go to my multiplanar view, which is a very useful view, and then the question is, okay, are the lateral ventricles separated? Yes, I can see it in coronal view, but is the corpus callosum present? And in my sagittal view, I cannot see corpus callosum. So this is a case of the agenesis, complete agenesis of the corpus callosum. Which are the indirect signs of the agenesis of the corpus callosum that we can pick up maybe more easily? Certainly, it's the presence of the colpocephaly that we can see on transverse scan, and colpocephaly not necessarily associated with ventriculomegaly, at least not in early pregnancy, that might then appear later in pregnancy. Last, other signs, there will be an upward displacement of the third ventricle, and what you can see here indicated with the blue arrows, we can have a bull horn anterior horns. So the anterior horns will be displaced laterally because, of course, we don't have the corpus callosum connecting the 2 hemispheres. And the last thing, we can have a diamond-shaped or triangle third ventricle. This should not be absolutely misinterpreted as the presence of the conceptive pellucidity. And what is very important in this case is the lack of the roof of the conceptive pellucidity, which is made usually by the corpus callosum. So in this case, we will not have this appearance. Also, we can use the Doppler, and in complete agenesis of the corpus callosum, there will be also the agenesis of the pericallosal artery. But not always we can have the situation so clear as the complete agenesis of the corpus callosum. We can have also some weird or more atypical appearance of the corpus callosum, as you can see some examples here. So we can have a partial agenesis of the corpus callosum, but also here we have to be a little bit careful, because in the literatures there are really different definitions of the cases in which we don't have the complete agenesis of the corpus callosum, but on the other side we don't have a normal corpus callosum. So the proposal that has been done by this group, and this is what we are using indeed in our clinic, and which is the most that resembles most what is the postnatal diagnosis and classification of the corpus callosum anomalies, is to categorize the abnormalities in complete agenesis of the corpus callosum, the partial agenesis of the corpus callosum, meaning that there is an absence of at least one of anatomically recognized regions. We can have the hypoplasia of corpus callosum, meaning that we have a thin corpus callosum with a normal anterior-posterior length, or short corpus callosum but no anatomical parts missing. And finally, we can have a dysplasia of the corpus callosum when we have a thick corpus callosum or unusual shapes, as you can see in these examples. So is MRI indicated when I have some corpus callosal apparently isolated anomaly? And the added value of MRI overall in complete agenesis of corpus callosum will be 11%. In partial agenesis of the corpus callosum, it will be 13%. But if we have performed a dedicated neurosonography, this percentage will be lower, as you can see. Which type of anomaly should I expect that will be depicted by MRI and not by the ultrasound? As we know, in the vast majority of cases, this will be malformations of the cortical development, and this is not surprising because we know that this is something that is very difficult to see with ultrasound. What is the additional added value of postnatal MRI or autopsy? So meaning that prenatally we can miss. In complete agenesis, it will be 4% to be expected, and in partial 16% to be expected. And this goes in line with the expectations that sometimes the partial agenesis of the corpus callosum has a worse prognosis than the complete agenesis of the corpus callosum. What should we expect from the genetic testing? We can have the added value of CMA. It's around 12%. The exome testing will add 43 to 47%, and when we have isolated agenesis of the corpus callosum, it will be around 30 to 32%. The postnatal outcome in isolated agenesis of the corpus callosum, there is some discrepancy in the literature, but the normal outcome is to be expected somewhere around 65 to 80%. In partial agenesis of the corpus callosum, the added value of CMA goes from 8 to 32%, and it's really very difficult to find the meaning or the added value of the whole genome sequencing. And the postnatal outcome in apparently isolated partial agenesis of the corpus callosum, the normal outcome will be again somewhere around 60%. So going further, we can have images like this, where if we ask ourselves if the lateral ventricles are separated, the answer will be no. And next, in these cases, we should ask ourselves if there is an absent cleavage also of the anterior cerebral structures. And if the answer is yes, then we are in case of holoprosencephaly. Of course, no doubt about a very easy definition of a lobar or semi-lobar holoprosencephaly. And as you can see here, these are very old images because many of these cases we would depict now in the first trimester. But not so easy the diagnosis of lobar holoprosencephaly, which goes into the differential diagnosis with the agenesis of the corpus cavum septipellucidi. So how can we do this differential diagnosis? In the cavum septipellucidi agenesis, differently from lobar holoprosencephaly, we will have no fused thalami. The corpus callosum should be normal. We will have normal falx cerebri, as you can see here, with indicated with blue arrow. In cavum septi agenesis, the falx cerebri it's normal, while in lobar holoprosencephaly we will have these anterior parts of the anterior part of the cerebellum will be fused, and the anterior cerebral artery will have a normal path in cavum septipellucidi agenesis, while in lobar holoprosencephaly it will be completely dislocated towards the frontal bone. And last but not least, not very easy to see always, but sometimes we can depict this, we will have separated fornices columns in cavum septipellucidi agenesis, while it will be fused in lobar holoprosencephaly, and you can see here the images indicated with red arrows. So then we can have a situation where the lateral ventricles are not separated, but there is no absent cleavage of the anterior structures. So in this case, we have to ask ourselves, is there any other alteration? Is there a hypoplasia of the optic nerve? Why this is important? It is important because if we have this situation, we will have septo-optic dysplasia. If we don't have this situation, then we have a situation of the agenesis, isolated agenesis of the cavum septipellucidi. So what is the septo-optic dysplasia? This is a syndrome that is made by clinical signs. We have to have two or more signs between agenesis of the septum pellucidum, hypoplasia of optic nerve, or pituitary dysfunction. So by seeing these signs, we can understand how difficult might be prenatal diagnosis of septo-optic dysplasia. And in this article published by Professor Guy and other authors, what is recommended, but of course this is the recommendation we would always give, that is in case of the agenesis of the cavum septipellucidi, the antenatal assessment of brain and optic pathways is recommended, but the discordancy between pre and postnatal imaging overall it's 14%. So even in cases in which we have assessed prenatally and it seemed normal, the appearance of the optic pathway, we can have a 9% diagnosis of septo-optic dysplasia postnatally. So this is very important because really when we are counseling our the parents, we have to inform them about this uncertainty of prenatal diagnosis and the exclusion of the septo-optic dysplasia. Now the next question is how to assess the optic nerve. The optic nerve can be nicely assessed by the MRI, you can see here, but also we can use the 3D imaging, and here you can see the render view of the evaluation of the optic nerve, and you can see how we have to put our box and our green line, which is the line of the interest, to see and to visualize the optic nerve. But we can also use the so-called tomographic ultrasound imaging, which is the possibility, as in CT, to have many very close slices displayed one after the other. And here, for example, we can really very nicely see the presence of the optic chiasma, the optic nerve, and posteriorly we'll have also the pituitary tubercle. Can we see the appearance of the optic chiasma and optic nerve also in two-dimensional with the real-time ultrasound? And here you can see an image. We can see the optic chiasma, we can see pulsating internal carotid artery, and we can see again the tubercle of the hypophysis that is located posteriorly to the optic nerves. And then we can have some special, very rare and special cases like this, in which that was depicted by the transverse scan and very small concept pellucidi. Then on multiplanar imaging, you can see that we have the lateral ventricles that are separated. We can see very nicely the corpus callosum. But then looking at the leaflets of the concept pellucidi, you can see that there is something very strange. It seems like there is only one leaflet. This is in two-dimensional ultrasound, and you can see that in some planes we can see two leaflets, in some planes we can see only one. And I will show you the magnetic resonance imaging, and we can see really that the resolution of the ultrasound, it's very important. It allowed to make the diagnosis in this case. And what was the diagnosis? The diagnosis was the partial agenesis of the concept pellucidi. So we can have this intermediate situation that can also sometimes precede the complete agenesis, because it has been described in the literature, the evolution from partial to complete agenesis of concept pellucidi. So to conclude, concept pellucidi is definitely a mandatory structure to be evaluated during anatomy evaluation, during the transverse plane. If there are doubts, then we should go for a coronal and sagittal view in multiplanar imaging. If there are still doubts, then we should send to the referral center. And of course, I hope that the roadmap for the differential diagnosis that I presented to you might be useful for you in your everyday clinical practice. And I thank you for your attention, and I will be very happy to take any questions after the presentation. Thank you.